The design is we're going to show about 3 or 4 different cases, and then I've asked the panelists to tell us what they really want to do. It's really nice in these meetings to not really tell people what you do, just show a bunch of data and then try to talk too long and get off the stage while there's still no questions to be asked. But I warned my panelists not to try to hide behind data, because I want to know what they really do. These folks all take care of thyroid cancer patients. They do it every day. And so you'll probably get very tired of me saying, tell me what you really do with this patient. And because all of us take care of patients, all of us do a good job, there are multiple different ways of doing this, so we're always interested in how we take care of this. I think one of the things that does influence how we make recommendations is the practices that we practice in. So I've asked each of the panelists to sort of give you a little idea about how they practice. In my setting, I work in an academic medical center. The vast majority of patients I see either for ablation or adjuvant therapy have been operated inside Memorial by very high volume surgeons. They've all had pre-op ultrasounds, many of them pre-op CT scans. We have wonderful pathologists, we have wonderful risk stratification. I'm always opinionated about radioactive iodine, but I'm an endocrinologist, so I don't really get to give radioactive iodine. So that means I have to be nice to my nuclear medicine doctors and try to talk them into doing the right things. How many nuclear medicine doctors do we have here? 1, 2, 7, 8, 12, too many. That's great, good. So we're wonderful that the nuclear medicine guys are here. So in my setting, I have to work with the nuclear medicine doctors, and we have a very shared decision-making kind of process. I'll introduce our panelists, and then we'll have each of them sort of tell us a little bit about their processes. Megan Haymart is an endocrinologist from University of Michigan. Kate Newbold is from the Royal Marsden, a clinical oncologist. In your guide, it probably said that Ujjal Malik would be able to do this with us. Ujjal had some family issues and couldn't come. And poor Kate made the mistake of answering an email from me, I think on Tuesday, that in the opening line it said help with an exclamation point. So we have thrown her into this mess at the last minute, and she graciously agreed to do this. Dr. Van Nostrand on the end, we are trying to wear out this morning as best we can, because he just came from the other early breakfast session between 6 and 7:30, and Doug's a nuclear medicine physician that's going to help us. So to help us understand sort of when I ask you how you treat patients, can I ask each of you to sort of explain the practices you're in? Do you give radioactive iodine? What's that decision-making look like? So that when we talk about the cases, maybe that'll influence how we do. Kate, you want to start?
Yeah, so thank you for the invitation stroke plea to turn up. It's fantastic to be here. So I'm a clinical oncologist, and in the UK that actually means a radiation oncologist, but we also give chemotherapy and systemic therapies. And in fact, most of the thyroid cancers in the UK are managed under the clinical oncologist. So we tend to see the patients post-surgery, and we give the radioiodine, and then they stay under our care really until sort of, the later advanced disease. So my practice involves giving radioiodine from the ablation setting to therapy setting, external beam radiation if required, and then the systemic therapies later on. So what we don't have is that having to change your patients from the endocrinology to the dreaded oncology clinic. So we do sort of skip out that jump, which may be beneficial, but that's the scope of the
So you in fact
practice.
are a multidisciplinary management team?
No, if only.
You talk to yourself? How does that work?
I look in the mirror a lot.
Welcome, Kate. Thanks for agreeing to do this. Yeah.
We work together. So in my clinic, I'll work with a consultant endocrinologist and nuclear medicine, and so we work together. So the nuclear medicines, it depends on the centre. Some of the nuclear medicine physicians will be giving the radioiodine alongside the oncologists, and we kind of do it together and share the practice.
Okay, still a team thing?
Yeah.
Be really close to the microphones the way they have it set, so pull it in there. Megan, pull that up closer since you're now ignoring me. Pull it closer, we can start that. There you go. Let's talk about your setting, Megan.
So I'm Megan Haymart. I'm from the University of Michigan. And so at the University of Michigan, we have about 40 endocrinologists, and there's 4 of us who work at the cancer center and see thyroid cancer patients. We work in a multidisciplinary setting. There's typically one of our 4 surgeons plus the 4 endocrinologists there every Tuesday. And for us, we'll see the patients, and for those patients that need radioactive iodine, we'll make the referral to nuclear medicine. There's 2 nuclear medicine physicians, and they typically decide on the dose. of radioactive iodine that's going to be given. And unlike with Kate, for our patients, when they reach the point that they're sort of high risk and they don't have iodine-avid disease, we do make the referral to oncology, which is sort of a difficult transition for the patients. So we work with a fantastic oncologist that helps us manage those higher risk patients as well.
Doug, can you talk about your setting?
I'm from MedStar Washington Hospital Center, and as I mentioned in the previous session, I've had the pleasure of working with a really outstanding team, specifically Ken Berman and Len Wartowski. For the better part of 37 years we've been together, which has absolutely been wonderful. We have a very strong team. We meet every Tuesday at 11 just for thyroid cancer. Occasionally there's something on parathyroid, but I don't know where that's located. It's just thyroid cancer for me.
Good.
We have 3 endosurgeons, 1 onc, 1 to 2 nukes present, a pathologist present, about, I don't know the number of our fellows present, but we're probably running 20 to 30 people in the conference, and we're very, very team-oriented.
Very good. So before we do the cases, I want to sort of set the background here a little bit, because the way we designed the cases is I brought 3 or 4 cases, 1 to talk about the ablative function, 1 to talk about adjuvant therapy function, 1 for treatment. Because back in the ATA guidelines, I think the last time and this time, we used these terms to sort of describe what the goals of radioactive iodine were. And in its simplest form, when we say ablation, we're talking about destroying that normal thyroid remnant, largely to facilitate follow-up, make thyroid globulins undetectable, and I think to get a post-therapy scan, which helps with risk stratification. In adjuvant therapy, we're using it in sort of the classic oncology sense, where you're treating somebody that might or might not have residual disease, but is at risk of having residual disease, recognizing that sometimes you're going to treat people that don't have cancer, but in the greater good, it's a good thing. You'll help more people than you hurt. And then in the last situation, we use the term treatment, which is we know there's usually distant metastasis, sometimes local metastasis. So at least in our shop, when we're talking with the nuclear medicine, we'll often use these terms ablation, adjuvant therapy, and treatment. Doug, from a nuclear medicine standpoint, do these terms make sense? Do you use them? Talk a little bit about that for us.
They make sense. Yes, we use them all the time. And when we really adopted them back in 2008, 2009, actually they formally came out in the ATA guidelines, as you know, Mike, in 2009 with Cooper. It really helped our conversations, because we may have, what happens is we frequently, and still do this, we'll slip and say, well, we'll ablate, but what was the objective? You're ablating to get rid of normal thyroid tissue, do a post-therapy scan, get your TG a little better? Or you're ablating to reduce recurrence, increase overall survival, progression-free survival. 2 very distinctly different objectives. So then, once we started using remnant ablation, as you define it, and adjuvant treatment, that helped at least for us to understand what the objective was, and not to create more confusion by each having different objectives for the word ablate. So they've been very, very helpful. I'm a big advocate of using those phrases and terms.
Megan, do you find it helpful? Is it terminology you guys use, or you don't worry about it?
So yeah, it is terminology that's used, and I think it's very helpful for the individual patient. So at our institution, they often do a pre-treatment scan, and then based on what's known from the surgical pathology and the pre-treatment scan, can decide if they're going to do ablation or adjuvant therapy. And so I think it sort of simplifies the communication with the endocrinologist.
So Kate, are these terms that are used overseas, do you guys think about this in this direction, or is it you lump them together?
No, we use these terms as well. So certainly we classify and differentiate between ablative doses and therapy doses. I suppose the adjuvant term we use less. Basically, after ablation, it's therapy.
So in addition to communication, Doug, does saying something's ablation versus adjuvant therapy sort of imply it's a difference in your administered activities, or how you're going to do the follow-up or post-therapy scan? Even before we get to the cases, sort of tell me, how do you think differently about somebody that I'm sending for ablation versus adjuvant therapy?
Well, you said you're sending for ablation. So is that remnant ablation?
I don't know.
Is that adjuvant treatment?
I also say dose and administered activity is the same. It's going to be a long 90 minutes, yeah.
So the one part of your question is, it first helps let me back up. So we have about 14 endocrinologists at hospital center that we service, and we have about 86 endocrinologists outside. So the first thing that we routinely service. So it's very important that when we're talking to that other endocrinologist, we're both on the same page on what the objective is. So that's the first thing that helps. So then if the decision is that we want to do adjuvant treatment to reduce recurrence rate, da-di-da-di-da-di-da, then we're going to have a discussion on prescribed activity. Now, as everyone in this room knows, one of the most controversial areas in thyroid cancer and I-131 is what's the prescribed activity for adjuvant treatment. But that helps us decide what the objective is and then to decide what the prescribed activity is. If it's remnant ablation, we're usually at the lower end with the Malik and Schlumberger study. So based on that, we're usually giving 30 to 50 millicuries because we're just getting rid of normal tissue. So those terms help us decide what category we're going to be in for the discussion regarding the prescribed activity.
And Megan, when you look at sort of what's your average, oh, wait a minute, I'm going to mess this up. Kate, dose versus administered activity, we throw those terms back and forth. What am I really supposed to say when 30 millicuries is what?
So 30 millicuries is the activity, so that's a reflection of the disintegrations of your radioisotope over time for a particular mass. So for your same radioisotope for different masses, you'll have different activities. But what it doesn't reflect is the absorbed dose in the tissue, in your target tissue. So as a radiation oncologist, we measure absorbed doses when we give external beam radiotherapy, but for isotope therapies, we're not entirely sure when we give an activity what the actual absorbed dose in the tissue is, which we measure in grey. And so the risk of that is that you're under-treating or you're not delivering an absorbed dose that's sufficient for cell kill. And so that's why, the dosimetric methods, which I'm sure Doug will be talking about later, is an area which we want to sort of improve on and have methodologies that are practical that we can use so that we can perhaps enhance or escalate the dose to the metastases, for example, and maybe even de-escalate as well in lower risk patients. But so yes, you prescribe activities at the moment if you're using empiric, but with dosimetric methods, we hopefully can then measure absorbed dose in grey to the target tissue and to the normal tissues.
And Megan, sort of as a general rule, without even a specific case, the administered activities you're generally going to use if your goal is ablation versus adjuvant therapy, what ranges are you really thinking about and giving for the average patient?
So I don't give the radioactive iodine, but typically for ablation, we think more in the 30 millicurie to 50 millicurie, and then adjuvant therapy would be 100 millicuries or up.
Yeah. Hey, Doug, let me ask you about diagnostic scans. I just came from the session that you gave this morning, and you gave a wonderful sort of description of diagnostic scans. When I'm trying to decide whether I'm going to do an ablation or adjuvant therapy, would a diagnostic scan help me in that, or do we make the decision based clinically? Can you talk a little bit about that, the controversy about diagnostic scanning, Doug?
It's controversial. The issue, and there's several points to that, so let me see if I can distill
take your
this.
time, 'cause I think it's really an important issue, Doug.
The goal is to risk stratify your patients as completely as possible, minimizing time, effort, money, etc. So there's a balance there. And in various meetings, in fact, I think Steve Sherman did a poll in the previous session on how many did diagnostic staging scans and how many didn't. It was probably maybe 75 that did and 25 didn't. And the issue is, why is there such a difference in practice patterns throughout the United States as well as in many other countries? And I've struggled with this, and I really think that one of the main reasons that's really talked about is technique. So we think about ultrasound, it's operator dependent. We all know that. And I used to do ultrasound. It's very operator dependent. If you do a chest x-ray is a chest x-ray is a chest x-ray is a chest x-ray, pretty much the same everywhere. when you think about a whole body scan, it's just a whole body scan, and it's the same at my place and the other place. They're not. They're very operator dependent, like ultrasound. So I think part of the problem becomes that a practicing physician really doesn't get much useful information from the radioiodine diagnostic scan and goes, you know, they're not really useful. Why would I even order them? The issue is they're probably not getting good quality images. Now, there are patients that shouldn't have radioiodine diagnostic scans, so then you have to divide it down. But I think a key message on diagnostic scans is technique. And so, as I mentioned in the previous panel, because this has come up, the article's already written. I'm not sure exactly where it will go, most likely thyroid, because I have a relationship with thyroid. And the article is for endocrinologists. Now, the newts in the rooms, the Dr. Anka, Avrams, and Balls, don't throw tomatoes at me, as we've discussed before. But the article is to empower the endocrinologists to be able to better assess the quality of their radioiodine scans that they're getting. And not just were they useful or not, was I getting a good quality scan? And I think that may help spur some of our own specialty to do better quality imaging. And the ultimate goal is to deliver information that alters management. So it's a complicated area. It's not simply a chest x-ray. It's more complicated, like ultrasound, and technique is really, really important.
Yeah, so it's one of those areas that you're going to have to stay tuned to. As somebody that does risk stratification, I'm very interested if I can find the right patients that the diagnostic scan would help us with risk stratification. So I think that concept of not every radioactive iodine scan the same really helped me understand that, and is now making me sort of rethink, okay, if I had that high quality scan, which patients would it make the difference? Doug?
Yeah, I agree with Mike, and the issue is certainly the philosophy is often less is more, and that's appropriate in many situations. But the concern is, are there patients moving into that category that shouldn't be in the low risk category, and how can we try to identify those patients? And diagnostic radioiodine scans can greatly help if good technique is used. And at least we're in the Washington, D.C. area, for better or for worse, and in the Washington, D.C. area, the reimbursement from Medicare for a radioiodine scan equals doing 2 thyrogen blood tests with antibodies and a TSH. So when you look at it this way, I don't think I never hesitate to order TGs. I probably over-order TGs, but I order a lot of TGs. I never worry about the cost. But I always hear, oh, those radioiodine scans are so expensive, we can't do that. They're really not very expensive. I'd like them to be more expensive, though.
Okay, now, we're now moving on before I get in trouble with the cost and how he needs to be paid more. He can take that up with Dr. Wartowski. All right, Megan, here's your case. Real patient, 27-year-old, newly married female, 3-centimeter nodule found by her GYN doctor, because obviously she was sort of thinking about having babies in the near future here, went for GYN exam. Suspicious papillary carcinoma, has a pre-op ultrasound done by your favorite people, whoever they might be. No abnormal lymph nodes were found. She gets a total thyroidectomy with no prophylactic neck dissection. And she comes to see you a month later. The path report shows a 2.5-centimeter classic papillary, no extrathyroid extension, no vascular invasion, no lymph nodes involved. At about the 6-week point, she's got a thyroid globulin of 1 with a TSH of 1.3 and negative antibodies. So Doug was talking about risk stratification and picking the right people for ablation. Before we even get to radioactive iodine, what's her risk look like now? Risk of recurrence, risk of death, risk of Doug doing a radioactive iodine scan? What are the various risks she might be exposed to?
So I like this question. So in the past, many of us would tell patients that they had a good cancer, and patients don't always like that. So there's been qualitative studies both by Saka at Toronto and by Rebecca Sippel's group at Wisconsin, where when patients are told that they have a good cancer, this can make them feel like you're minimizing their cancer and sort of minimizing how they feel about it. But I do think it's important instead that we can sort of explain the risk to them and explain also the benefits to them, and then they can sort of make their own assessment. And then when we do this, we have to be sort of careful because there can also be issues with numeracy literacy. meaning that sometimes, a percent doesn't mean the same thing to everybody. So you might say 5%, then you might have to again say it 5 out of 100. And so for myself, I typically talk about the risk of death from thyroid cancer, and I try to reassure patients with the numbers. And then I'll also talk about the risk of recurrence. And when I talk about death from thyroid cancer, there's a couple different things I'll do. So I have an extra slide. So there's different algorithms that you can use to explain to your patients. And so sometimes, I'll actually use visuals. Other times I'll just use words, and so it sort of depends on the patient. So for this particular patient, she has localized disease. Her age is less than 63, and her 5-year survival based on SEER data, which is a population-based database, and it's with data between 1998 and 2005 with a median of 7.5 years follow-up, would be that her likelihood of death from thyroid cancer is near zero. Likelihood at 10 years is also near zero. But if you look at the SEER data out of 22,000 patients, there's still 42 patients that die. So those are sort of the absolute numbers. But this can sometimes help reassure patients when they hear the cancer and they're worried that they're going to die, that's sort of lower on our worry list. With many of our patients, though, we're still concerned about likelihood of recurrence. This particular patient, that's even not a huge worry. So if you can go to the next slide. So this was put together by the ATA guidelines. It's from the 2015. And it's a nice visual because it shows that risk is really a continuum. It's easier for us in our brain to sort of categorize things. And so we do categorize into low, intermediate, and high risk. But it's actually sort of a spectrum. And so, you can use this. It's an interthyroidal cancer. She didn't have any lymph nodes involved. Probably the likelihood of recurrence is going to be low. So she's, at low risk of recurrence. She's at low risk of death from thyroid cancer. Neither of them are completely zero, but they're low. And so hopefully by sort of presenting the numbers to the patient, they can sort of make their own assessment of how they feel about their cancer.
Okay, she happens to be in London. She comes to see you. And the question is, does she need radioactive iodine ablation? And don't tell me she gets a choice, because she's one of these wonderful patients that says, Dr. Farnell, I came all the way from New York to see you. Just tell me what to do. What do I do?
So on the face of it, she has, as Megan's just explained, a very low risk thyroid cancer. From what we know, she's got no adverse features of her T2. So she's a PT2, CN0, CM0, classical papillary. We haven't been told that there's any subtypes of any poorly differentiated aspects. I'm assuming not. It's no extrathyroidal extension or lymphovascular invasion, and so her risk of mortality from the disease, as you've said, is minimal. This is not going to shorten her life. And any intervention now is reducing the risk of recurrence, and then
We're
the
stalling,
subsequent
Kate. We're
interventions.
stalling. How many people would like to know whether or not Dr. Farnell would give radioactive iodine? Would you like to know? Would you like to know? Please pay attention. We got an hour. Okay.
The lucky thing I have is I can recommend a trial for her. So she can go into the ION trial in the UK, which is where we are randomizing these low-risk patients into receiving iodine or not. And if she doesn't want to go into the trial, then still our standard would be low-activity radioiodine. However, she is in what we call the individualized decision-making group. But of course, there are other things to take into account here. She's 27, she may be wanting to start a family, and all these things need to be thrown into the mix of the discussion.
Megan, if we put you in charge of nuclear medicine at Michigan, and you didn't have ramifications of dealing with anybody, you got to practice all by yourself, radioactive iodine, yes or no?
So we still have a discussion with the patient, so some of it would depend on what they want to do.
Maybe I'm not really being clear. Are my questions unclear? Because I'm done with you guys. Radioactive iodine, yes or no? How many people say yes? Do we care what Randolph says? I don't think so. How many people say no? No, oh my God. Okay, nuclear medicine only voting? Nuclear medicine only voting? Nuclear medicine yes? Uh-oh, Doug, nuclear medicine no? Not you, settle down. Nuclear medicine, yes, okay. Doug, radioactive iodine, yes or no?
I will give you a definitive answer. but
Maybe.
After two statements first. One is I still
See
want
why
to
they stuck me with this panel? This is why.
we love Mike. We still want a diagnostic radioiodine scan, although the yield will be low. I want to fully stage that patient, and I recognize that it will most likely not alter anything, and I'm comfortable not doing a remnant ablation. Of note, that decision is not made by me. It's made by the endocrinologist, because if they're not doing remnant ablation, I never see the patient. I also want to make one other final comment. I made a joke about the higher prices. I want to recover from this. I'm at a stage which is of my life that's very enjoyable, because I receive no money for doing a scan, I receive no money for therapies, I don't even charge my patients, and I receive no salary from MedStar Washington Hospital Center. I don't have a horse in the race for money. It's only, from my perspective, is what's best for my patient.
Holy cow, I want you to do contracting with that. I don't do anything for free. I'm still trying to, I go fishing for free. I'm still trying to think through that. That's a really important concept, because as much as we tease, I think if you had a diagnostic scan and it showed something, we wouldn't ignore it, right? So what's the likelihood? So I think that's a good question. And I think we're in an area like this, it's not right or wrong to treat this lady with radioactive iodine. She really is in that middle risk thing there. Megan, a lot of these guys are getting molecular testing now before they have their thyroid cancer, even if you're not doing it on the tumors. What if you knew this was BRAF V600E? It's a classic BRAF mutation on the FNA before the surgery. Does that change what you do?
So I do have a story from U of M. So first of all, I believe the data that came out by Zing et al., where BRAF is a prognostic indicator, but it's not an independent prognostic indicator, meaning that if you have a good surgical pathologist, it doesn't typically add any information. At U of M, and they started testing for BRAF, and then none of us were using it in our clinical decision making. And the problem was that the patients were getting that information, and it had like a little disclosure below it that said that this is associated with worse cancer. So instead, the endocrinologists and the surgeons were having a lot of patients call us, very anxious about it, and they even misunderstood it. Like one of my patients thought it was like a germline mutation, where his family would be at risk for it. And so we met as a group with our surgeons, the endocrinologists and the surgeons, and we felt like, it wasn't changing what we would do clinically. And for, all comers, we didn't think there was any benefit in testing for BRAF. So we actually stopped testing for it. We're revisiting the topic of doing molecular testing, but more in our select, very high-risk patients, the patients that we would send to someone like Kate in oncology, where we're considering like a tyrosine kinase inhibitor or a clinical trial. So we're revisiting whether or not these are patients that we need molecular testing in, but that's 5% of all of the patients we see. So for all comers, we don't really think that there's great data that the BRAF is beneficial in our decision making.
So Kate, many of these patients are right on the fence, and depending on who's paying me, I can give you just as good a lecture. They need to be ablated as not ablated, depending on which side of the argument I'm assigned to. But what do you tell this young lady about sort of the real risk of radioactive iodine? I hear some people just scare them to death so they won't take radioactive iodine. Other people pretend like it's water. What do you really tell her if she's not really made a decision one way or the other, and it's the risk that's going to weigh her one way or the other?
So we'd be giving her low activity radioiodine 1.1 or 30 gigabecquerels or 30 millicuries, and using recombinant TSH to prepare her so the whole body dose is going to be low. So I would say that the risks for her are low. I wouldn't feel uncomfortable about giving her low activity remnant ablation if she felt more comfortable with that herself. For a young woman, I emphasize the fact that this is not going to affect their fertility long term, although it will delay getting pregnant for 6 months, we advise, and a slight increase in miscarriage up to a year after the iodine. That the potential side effects that she'll get will be usually short-lived, so the sialadenitis is unlikely to be long-standing for her with a low dose prepared properly. So I think, I would go through it, I would go through the side effects, but I would be reassuring with this as well.
Doug, I'm going to bump a little bit into the adjuvant therapy sort of administered activity. What's the side effect profile, 30 versus 75 versus 100? Any substantial difference there, or what do you think on that?
Yes.
And it'd be what? You're not getting out that easy.
Well, I was trying to be definitive for you.
Oh, yeah, you pick one thing to be definitive on. Are we going to finish at 9?
It just
Yes.
makes logical sense, and there's data to support this, that side effects are related to prescribed activity. It's not completely related to prescribed activity because it also involves, of that prescribed activity, how much uptake is there, what's residence time, and these are all part of what our physicist does. So as the dose goes up, in general, prescribed activity goes up. As the prescribed activity goes up, the radiation dose goes up, and your side effect profile goes up. However, there's an important footnote to it. We spend, in our dialogue, an awful lot of time on reducing side effects by reducing prescribed activity. I think we need to spend equal amount of time, if not more amount of time, in the management and reduction of side effects, which we're doing better and better, but we don't do enough of, so that if you're giving 75 or 30 or 150, really aggressively managing those patients for sialoadenitis, for transit time in the GI tract. If it sits there for several days, that's a lot of radiation exposure. Mm-hmm. If it's sitting in the bladder all night, to be aggressive in the management of those side effects. So it's side effects are related to prescribed activity, but there's much more than just prescribed activity, and aggressive management can reduce side effects.
Megan, I hear everybody's using this post-op thyroglobulin at 6 weeks. The guidelines say you should do it, but we don't know how to interpret it. We don't know what the cutoff should be, but we really, really think you ought to do it. That's always fun for guidelines. What do you do with the post-op TGS6, and is there a cutoff that you use to decide for ablation or not, or adjuvant therapy? Just from a practical standpoint, how are you using that?
So I agree. I mean, it's nice compared to some cancers, there's no tumor marker. You know, we do have a tumor marker for thyroglobulin. And the benefit of it, you know, you have to take it into context. So it depends on how much thyroid remnant is left. It depends on what the TSH is. We also take into account what the post-op pathology is. But I think if you take it in clinical context, it is typically helpful, although it doesn't give all of the answers. So, for example, her thyroglobulin is 1 nanogram per ml. That's low. You know, so it's likely that she doesn't have any other disease, but it's not absolute. So there are always going to be patients who are going to be outliers. If the thyroglobulin is 5 to 10, you know, we'd be concerned and think, well, maybe she does have some residual disease. But again, there are other patients who have a very large remnant that can also make a thyroglobulin of 5 to 10. We do pre-treatment scans at our institution. You know, so that does give us a little bit more information. But I still think that thyroglobulin is helpful if you take it in context, and if you know that it's not an absolute, there's going to be some outliers once in a while.
Doug, I think all of us, if the thyroglobulin came back at 5 or 10 or 15 or 20 or 100, would worry. That would lead us towards structural imaging, paying attention. What about the opposite? In a low-risk patient like this, if your post-surgical thyroglobulin is undetectable, either stimulated or not stimulated, do you still need to do a diagnostic scan to make the decision of ablation? Or in a low-risk patient, is a really low thyroglobulin good enough for us to say we don't need to go that pathway?
I don't know the answer to that, and so based upon prior practice, I'd still like to fully risk stratify that, and if they have a negative scan and an undetectable TG, I'm a happy camper. The fact of the matter is an undetectable TG isn't perfect either, as we all know. So I think for a simple scan, not too expensive, without complications, I think it's reasonable to do the scan. So I'd like to do
interesting. I think that's an area I think we really have to look at, where you sort of cross over what's the pretest probability of finding something. And
well, I think there will be categories where, you know, it's the cost of a quality life year. And so if the threshold is $30,000, I forget what it is in Britain right now, someone might know, that needs to be assessed, and that may not be the appropriate place then to spend the money when you're not getting enough quality of life back. But until that's done, you know, I don't have a problem doing the pre-staging diagnostic scan. But again, that decision is usually made before the patient
Right.
gets to me.
So it's obviously something we're talking about. Megan, she's decided she wants radioactive iodine. She likes the decision that 30 millicuries doesn't seem like it's going to hurt her. She wants to make your life as easy as possible with low-level TGs. The trouble is she has a very loving father-in-law who just sent her on a cruise for the next 3 months around the Mediterranean. Can she wait 3 months to do her radioactive iodine?
So I think she should go on our cruise, so she's low risk.
So at the end of the cruise, she calls you back, and she was going to study abroad for 6 months. Is that okay?
So,
Simple yes or no?
yes,
Simple?
yes, but then
Okay,
can I
cool.
talk? No worries.
So now she's abroad, and she wants to do a year's study because she found a new husband and a new boyfriend. Is that okay?
so at that point, someone...
I'm asking about the boyfriend and the husband part. Is that okay?
So
It was Italy. It could happen, so it's good.
So at that point, we'd have TGs, we'd have neck ultrasounds, and we'd have more information to re-risk stratify.
So realistically, if somebody needs ablation, what window are you looking at for individual folks?
So there's a paper that came out in Thyroid in 2016 by Sheffel et al., and they looked at likelihood of persistent disease, and it was over 500 patients. And if you waited, if it was less than 6 months or more than 6 months, the majority were stage 1, like 60% were stage 1, and it really didn't make any difference in likelihood of persistent disease. And then there's been data with NCDB that was in endocrine practice in 2016 by Suman et al., and they looked at overall survival. This was a higher risk cohort than this, so these are patients with a tumor 4 centimeter or larger, they had lymph node involvement, or grossly positive margins, and they looked at greater than 3 months or less than 3 months, and there wasn't a difference in overall survival. But I think for patients we're more interested in risk of persistent or recurrence disease, so probably the Sheffel et al. Was a more helpful paper, and it was more low-risk patients like this. But I think easily she can wait 6 months, and probably there's not going to be any adverse effect. And then if it's 6 months and all these other things start happening, she's traveling, whatever, we at least have time to re-risk stratify. So we'd have other thyroglobulin levels, we'd have neck ultrasounds, and we could sort of make decisions moving forward. What I don't love when it happens, and especially she's 27, she's not 37, but I have seen patients who, basically stopped their life because they had a thyroid cancer diagnosis. And that, I think, is unfortunate. And I think to a part we haven't done our job well, especially if it's a low-risk patient like this, if they sort of, stop doing the things that they want to do in their life because of their thyroid cancer. I think that for most part with a low-risk patient, we can sort of work with them as long as we, sort of appropriately re-risk stratify. But I think we have to take into account, sort of the things going on in their life as well.
I think that's a critical point. There are studies, and patients will, if you ask them to tell their life history before they had thyroid cancer, they'll tell you about major points where they had children. I graduated from college, I did that. And after the diagnosis of thyroid cancer, their story is often before and after that diagnosis of thyroid cancer. Doug, along those same lines, this issue of wanting to get pregnant as soon as possible, I often see professional women in Manhattan that have delayed having babies till they're 38, 39. They get diagnosed with thyroid cancer, and they really want to get pregnant in a month or 2 months or 3 months. Does that sort of, in plus, what do you tell them in terms of giving radioactive iodine? Do they really have to wait 6 months? In somebody that's late 30s, early 40s, is the radioactive iodine going to have any impact on their ability to get pregnant? How do you counsel those folks?
Well, I think actually Kate addressed some of that in her comments earlier regarding the data. I'm sorry. So Kate addressed some of this already earlier, and the guidelines address a lot of this. So if the patient wants to get pregnant in this situation, I'm assuming that serum TG is a stimulated TG also. Is that correct?
Yes.
So I don't have a problem if she wants to get pregnant now and to postpone the remnant ablation if that's what the plan is. If she wants to have the remnant ablation at this point in time, as Kate's already pointed out, there's some data for amenorrhea that's short term, some data that raises the possibility of increased miscarriages early, but the data is soft. Generally, we say 6 to 12 months you wait. It's fairly arbitrary in one sense, so I wouldn't have problems if I was making the decision to do an I-131 therapy I wouldn't have a problem doing that and waiting 6 to 12 months.
Kate, we've all sort of settled in on this 30 millicurie-ish dose for ablation, these lower stuff. Can you talk about the studies that really compared that, 30 versus 100, and also thyrogen versus hypothyroidism, sort of those studies and your approach if you had unlimited data, unlimited access, thyrogen was available in a water cooler in the back. Would you do ablation? Would you do thyrogen? Sort of your general approach there.
So we base our practice on the evidence from the two randomized controlled trials, the HILO study, which was carried out in the UK, and Martin Schlumberger's estimable study that was carried out in France, and both were published in the New England Journal of Medicine in 2012. And those had very similar designs. So the patients were low risk, they were randomized between recombinant TSH preparation or thyroid hormone withdrawal, and then subsequently randomized between 1.1 gigabecquerels, 30 millicuries, or 100 millicuries, 3.7 gigabecquerels. So we had, and the results from both of those studies showed equivalence in that you could give recombinant TSH and 1.1 and have the same ablation success rate as if you had thyroid hormone withdrawal and 3.7. So that shifted our practice. And we now use that. The eligibility criteria for the two studies was slightly different. In the UK, we allowed T1 to T3 and N1 positive disease. And when we look specifically at the T3 and the N positive disease, they had similar ablation outcomes. So in the French study, only N1 disease in the T1s was permitted. So the French study had slightly lower risk disease within it. But yeah, so I would now prepare my patients with recombinant TSH and give 1.1 30 millicuries in this situation.
Megan, we sort of pretend like ablation and adjuvant therapy are two completely different boxes, but every once in a while you give 30 millicuries and you light up on the post-therapy scan small volume lymph nodes or rarely diffuse lung metastasis. Have you done adjuvant therapy? Did you give them enough dose, 30 millicuries? Do you bring them back and give another dose? What do you do when you give an ablation dose and yet the post-therapy scan shows what you think is real disease?
Mm-hmm. So typically our nuclear medicine would bring them back in 6 months and then do a hypothyroid protocol and then see if additional treatment's needed at that time. So, we don't see that very often, so it's an infrequent finding, but in the few cases that's happened, they'd sort of reassess at 6 months.
Doug, do we know whether 30 millicuries, we say it's an ablation dose, could it be an adjuvant therapy dose? We've sort of made these arbitrary boxes. If you have really good lesional dosimetry like Kate was talking about, are we really doing adjuvant therapy with 30 millicuries?
Well, and I can't remember what I've said earlier or not. And that may just be age or I'm talking too much. But this is one of the most controversial areas regarding thyroid cancer and I-131. So the spectrum is that for adjuvant treatment, again, adjuvant treatment has the objective of reducing recurrence, increasing progression-free survival, da-di-da-di-da-di-da, that you can go with 30 millicuries. And the opposite spectrum is you could go with 100, 150, and even farther to go to dosimetry. For me, the first thing is that when one is talking adjuvant treatment, you haven't said anything about the situation of the patient, and it needs to be individualized. And Mike, you and I have discussed this before, that a patient with a couple of lymph nodes that are positive, 0.3 centimeters, not even the 0.2 centimeters per the ATA guidelines, I might be less inclined to go with a super high dose or dosimetry than someone who had 20 or 30 nodes positive, a little invasion of the trachea, and the surgeon thinks they scraped it all off, but you don't know. There's a high likelihood that there's lymph nodes left. There's probably some left at the trachea. That patient is distinctly different than the other. So adjuvant treatment, just as a category, needs to be subdivided. And in that particular patient, I'm looking at higher doses of I-131, and I'm looking at dosimetry. The fundamental concept of radiation therapy to kill a cancer is you got to deliver enough rads, that's the dose, to kill the cancer. It's not enough. So if you have a head and neck tumor, you want to get 7,000 rads. Well, we can do that easily with XRT, but as mentioned earlier, we don't know if we're delivering 8,000 rads per Harry Maxim's early data and other data, and our data also. But we need to get to that to do and give a kill. So if I'm thinking that a patient with 20 to 30 nodes positive, cancer left on the trachea, I want to give as much as I can safely in order to increase my likelihood that I'm going to deliver a tumoricidal dose of over 8,000 rads to that cancer. So I think it all depends upon the individual patient that you would present to me. I generally lean towards higher doses because I'm trying to reduce recurrence.
Yeah.
One final fact that and this is an issue within nukes, radiation therapy can deliver XRT uniformly to the tumor and then try to minimize with IMRT, gamma knife, cyber knife, et cetera, and pretty much control that. Not only don't we know what we're delivering for dose, radiation absorbed dose, gray or rads, but it's not homogeneous. These cancers are heterogeneous. And so I might deliver 8,000 rads to 75% of that tumor, but I got 25% of the tumor that's getting 3,000 rads, and that's going to recur. I got to get 8,000 rads or more to the whole tumor to really make a difference.
Very nicely well said, Doug. Kate, let me ask you one last detail about the radioactive iodine scanning and therapy. It has to do with the low iodine diet. Do you put folks on the low iodine diet in the UK? Is it necessary? And then we'll ask Megan the same thing.
We do put our patients on a low iodine diet. We're a little bit relaxed about it. We have quite a low iodine dietary content in the UK. And I think, we're a bit wishy-washy about it, to be honest. But we do ask them to adhere to it for 14 days, but we're not really that strict on it. We don't do urinary iodides, so we sort of nod towards it, but
middle of the road,
yeah.
kind of. Megan, you guys are low iodine religion, not low iodine religion? Which camp?
So low iodine religion. So the patients do go on a low iodine diet. They hate it, but we sort of routinely use it for our patients.
It is amazing when you tell somebody they have to go back for either another treatment or another scan.
Yeah.
That actually, I generally get less complaints about the side effects of the radioactive iodine. They all want to know, do I have to go back on that diet for 2 weeks? Megan, finish this case up for me. She chose not to do radioactive iodine ablation. What's her follow-up look like over the next sort of 6 months, a year, 2 years, just sort of in general?
So for her, we would follow her unstimulated thyroglobulin, and we would do bedside neck ultrasounds. And if her thyroglobulin was low and stable and her neck ultrasounds looked fine, we would continue to follow her for 5 to 10 years. At some point, we might transition her to her primary care doctors. That's actually been a topic that we've been discussing a lot at U of M and haven't decided at what point we should transition our patients to their PCPs. For breast cancer, it's at 5 years. We definitely follow our high-risk patients for 10 years or more. Anyone with biochemical evidence of residual disease or structural residual disease, we continually follow them. But we are sort of debating when to transition these low-risk patients to their PCP. After the first couple of bedside ultrasounds, if the thyroglobulin, is undetectable or very low and stable, we may stop doing bedside ultrasounds because sometimes you'll just pick up, false positives and worry the patients more. And then we'll use our thyroglobulin as a cue as far as when to add the bedside ultrasound back.
Yeah. Kate, long-term follow-up in the UK? I mean, I get this impression that they have nodules, they get seen once or twice, then they get sent to their primary care doctors. What's that follow-up look like in the UK?
I think it's variable, but actually I think a lot of centres keep their patients under long-term follow-up, but because historically thyroid cancer has been followed up by different specialties, it is pretty variable across the country. I follow up all my patients for life at the moment, but obviously that is getting unmanageable. So
they will wear you out.
We're starting to do a sort of more of a remote, just looking at the biochemistry. But if more and more people are discharging to our primary care, but with very clear definitions of what the TSH range should be,
which is the
etc.
theme in lots of oncology, right? What's the point you can transition back to your primary care with a cookbook that says these are the things you need over time? All right, let's take it up one level. Let's look at adjuvant therapy. And as Doug talked about, there's a wide range of adjuvant therapy. So I picked one that's sitting right at the higher edge of adjuvant therapy. some right bordering along. So there's no question this is not 2 millimeter lymph nodes. This is real disease. 35-year-old lawyer. His mom is the president of the hospital, and his dad is the local judge. So don't worry, I'm certain this is going to go well. Would anybody like to just go ahead and give radioactive iodine at that point? That's what I would do, and I'd send him to MD Anderson and make him Steve Sherman's problem. 35-year-old lawyer, palpable lateral neck lymph nodes for nearly a year that didn't go away in response to multiple antibiotics. Somebody eventually does a physical exam, because if you're really desperate and you can't get the ultrasound machine to work, you still can feel people's necks. A 4-centimeter nodule in the thyroid. Ultrasound confirms big lateral neck lymphadenopathy. We're here in Boston, so where's Randolph? I have to admit, we did a CT scan with contrast. Chest x-ray was absolutely normal. Gets a total thyroidectomy, central and ipsilateral neck dissection. The op note says all gross disease was removed. Is that like the default? Do you guys put that in all your op notes, or Jerry, does it just automatically come in your synoptic note? Everyone, he says. Okay, so all gross disease was removed. The pathology shows a 4.1 centimeter tall cell variant, lymphovascular invasion, microscopic extension into the overlying strap muscles, a neck full of lymph nodes, 23 out of 38, 6 out of 10. Largest lymph node is 3 centimeters. Several have extranodal extension. This was a several-hour-long operation to get things all taken care of. 6 weeks after surgery, Megan comes back. Serum thyroid globulin is 12, no antibodies. The surgery was actually done by an outside surgeon that I didn't particularly know. And so as part of that evaluation, we actually did an ultrasound at that 6 weeks as well, because there was so much disease there. You painted a pretty rosy picture for the last young person. Let me ask you the same thing. Risk of dying, risk of recurrence, persistent disease. What's the gestalt you give this young lawyer?
So this is different than our other patient. I'm still very optimistic in regards to survival, but then he's very high risk for recurrence. If you go to the next slide, I'll show. So there's different ways to look at it, but for patients with regional disease who are less than age 48, they still have an excellent 5 and 10 year survival. So it's essentially 100%. But out of 8,000 patients, 30 or so are the crude numbers that would die based on the SEER data, which is population-based data. And so this patient's young. Likelihood of death from his thyroid cancer is very low, but he is going to be high risk for recurrence. So again, this is from the ATA guidelines, but even just, in general, anyone that's seen patients like these knows that there's going to be a high risk for recurrence. So especially he had some extranodal involvement, he had a lot of lymph nodes involved. So recurrence, is in the 30 to 40% range. And usually I'll tell them that up front, so I'll say that, we're going to follow you long term. We're primarily concerned about whether or not this cancer is going to come back and that we pick it up at the right time. And then we work with your surgeons on whether or not a second surgery is needed versus, if radioactive iodine or external beam or something else is needed at that time. And so I try to be upfront with the patients so that they have sort of realistic expectations. And, that works well for the most part. I do have to say, I think that the patients that struggle the most is after this point. There's those that we essentially feel like are cured, those that have really aggressive disease, and actually we're worried about them, but we're sending them to oncology, we're putting them on tyrosine kinase inhibitors, they feel like we're doing something. The ones that have a lot of worry are sort of those in between, where maybe they have some biochemical evidence of residual disease, they had aggressive disease initially, and we're sort of monitoring them, and that can be very nerve-wracking for the patient because they'll feel like, oh, you're not doing anything about my cancer. So for him, I'd reassure him on survival and let him know that we're going to follow him closely. He has a great team of physicians taking care of him, but a 40% likelihood of recurrence.
Kate, follow up on that same theme. This feels like half of my clinic, because this is the outside consults we get in. They all start with N1B disease. They all start with this exact same story. And every week I see somebody that's stunned at 1 year they're not cured.
Yeah.
How do you set that right? What do you really tell patients from practicality?
No, it's absolutely. You've hit the nail on the head with these ones, in that I really do need to manage or try to manage their expectations from this point. So like Megan, I would be positive. He may respond extremely well to the iodine. We don't know that yet. But I would say at this point that it is quite likely that he'll need more than one administration of iodine, and not to be, sometimes I've had a patient like this recently, and I did say, you know, it may be that on the post-therapy or post-ablation scan, we see some uptake within the lungs. That is not unlikely in this situation, just so it's not a complete shock and panic when you get to that. So just sort of planting those ideas at this point, and then you can build on that, and it's less of a kind of fall or a shock with information that comes out, because, you know, he is at risk of having some microscopic lung disease that's picked up on the post-ablation scan. He is likely to have more than one iodine. I would talk about possibility of fertility preservation. He may need more than 2 doses, and sometimes, you know, if they're slightly anxious about fertility, then we'll just bank up front to ensure that that's preserved.
Doug, let me give you pick 2 administered activities for me. One, this is somebody that clearly we would do a diagnostic scan on to help inform us, without a doubt. The first scenario is diagnostic scan shows just thyroid bed, no lymph nodes, no nothing. The second scenario, you light up some small lymph nodes in the neck and some small stuff in the lungs. You've already done cross-sectional imaging. This is not big volume lymph nodes, it's small stuff. But in the scenario where your diagnostic scan shows no evidence of disease outside the neck, what administered activity? And in the same patient, the scenario shows some little small lymph nodes or some small pulmonary. How would you pick the doses there?
So this case just speaks to what I was saying before, that for adjuvant treatment, a lot depends upon the specific situation of the patient. So in this particular patient, and your first scenario where the diagnostic scan is negative,
Yes.
or negative for any evidence of local regional disease or distant metastasis, I would look at a higher empiric dose, or in this particular patient, would consider dosimetry. Now, I do admit a bias, but in my practice, this is the patient I see in 12 years. Because in 12 years, these patients are coming back, and that follow-up is long-term is important. They're coming back at 12 to 15 years with recurrence and bone mets and lung mets. So because of that experience, I'm more aggressive. Now, the majority won't be in that category, but now is the time to try to treat that patient. Now, I don't make the decision that it will be empiric or it will be dosimetry. I usually have that with the endocrinologist and with the patient. So I explain the pros and the cons. To digress, one of the interests, I do a lot of speaking for the THICA survivors group, and one of the things that always surprises me at those meetings with those patients is nobody ever told me that. So that's affected me in the sense to say, here are your options. You have an empiric dose, you have a dosimetry dose, and I have the luxury of time to go through this, and here are the pros and the cons. And generally, they will make the decision. The joke is often that what they usually were saying was, if this was your wife, what would you do? Now they say, if this was your grandchild, what would you do? But so, having said that, they will usually make the decision, and then they have participated in that. But I would be, so in the empiric, I'd be pushing 125 to 150 millicuries. And if we go dosimetry, then I will, if we came into the 300 or 400 category, I wouldn't be going that high. I'm going to build in some extra safety in there. And if they chose dosimetry for this patient, I would consider that.
Yeah. Help me, Doug. We've got this data from Bayer-Walters, we got the data from Schlumberger and Cosimo-Durante that were just straight fixed doses. There was not hard thinking about it. You got a fixed dose. As opposed to us doing, and we're like you, we do dosimetry and sliding dose. How do I put those 2 pieces together? I mean, is it the same group of data? Do I really think dosimetry is better than fixed dosing, or are we still one of those we don't know yet?
Well, what Mike is referring to is a recent publication, as Mike pointed out, and a commentary and some by me in the Journal of Nuclear Medicine, humbly. And I think one needs to be careful. And so you know my viewpoint already. Sure, yeah. But for the audience, the article suggested that there was no, and it's a nice study, and Mike and Martine Schlumberger involved with it, that there was, they didn't have the ability to show a difference between empiric doses and dosimetry. But it's a cliche, but it's an important one. An absence of evidence is not evidence of an absence. It's just that you are unable to show a difference. Now, if one goes back and looks at the data, so I was arguing the other side of this, when you really look at, and I won't go into the details, but when you look at the patient populations, they are distinctly different. There's no doubt about it. Higher age in the Memorial Sloan Kettering, more men, they had more chemotherapy, XRT. All of this speaks that this was a more difficult patient population. And so when one comes and looks at prima facie evidence to say, well, there was no difference, they must be equal. The fact of the matter is, Mike and Benoit and Leeper was the one that taught me. The fact of the matter is, maybe those patients indeed had worse prognosis, and the fact that they had dosimetry gave them a life survival that now equaled those patients with a less severe prognosis. So one has to be very careful in the assessment of the data. Now, if I have the time, I want to make one other fundamental comment. One of the arguments against dosimetry is, until we prove that dosimetry is superior to empiric doses, we should use empiric doses. I don't have a problem with using empiric doses. There's issues with hospitals, support. Empiric doses are fine. I think that's a standard of care. But I don't buy the argument that until we prove dosimetry is better than empiric, that we should only go with empiric. The fundamentals of radiation therapy are two. One is deliver enough rad dose to the tumor to kill it. The second is minimize the radiation exposure to the normal tissue. Empiric doses do nothing with that. Now maybe if you go low enough, you're reducing the side effects, but dosimetry at least attempts not to exceed the unsafe dose of 200 rads to the bone marrow, and we're making progress with I-124 now, PETs as well as Memorial, Steve Larson, Alan Ho, et cetera, to get lesional dosimetry. But at least with dosimetry, if it's available, one is at least trying to address one of the two fundamentals of radiation therapy, and that is not exceeding a safe dose. And Mike's published from his institution, Dr. Kulkarni from our institution, that in many of these patients at 150 millicuries or 200, you're exceeding 200 rads to the bone marrow.
Very good. Megan, you were pretty flexible about sort of the timing in our last lady for ablation. You didn't really seem to care whether it was a month, 2 months, 3 months. What about this fella? Obviously, many of these guys want to be treated yesterday because they're scared, but some of them don't. They need to get back to their practice for a couple months, or they have something coming up for 6 months. What's the, I guess, for you, optimal time horizon for adjuvant therapy in an admittedly higher risk patient like this?
So in this one, I would encourage them to get it in the first 3 months after surgery, and it's especially because, like Kate mentioned, there is the chance that he's going to have some distant disease, and the patient is younger. So there's also the possibility that he's going to be very iodine avid, and that radioactive iodine, although it may not be curative, it also might help control his disease. And so, for him, I'd probably encourage him to get it in the first 3 months.
So probably leaning sooner rather than later, but that's good. Kate, back to our two preparation methods, hypothyroidism, thyrogen, limited supply. You can do whatever you want to. There's no restraints in whatever economy you're doing on. What are you thinking about of patients for adjuvant therapy, hypothyroidism versus thyrogen stimulation?
I still give recombinant TSH in this situation.
You still give recombinant TSH in this situation?
Yeah.
Okay.
I'm being definitive.
You're being definitive? I like that. It scares me a little. Doug, you want to be definitive?
In adjuvant therapy, the lower risk patients, I have no problems whatsoever with thyrogen. And certainly for remnant ablation, 95% of all of our remnant ablations are with thyrogen. In the patient that's more complicated, I do like patients to know the options. Yeah. So we'll present those options, a thyroid hormone withdrawal versus recombinant human TSH, with the pros and the cons. And again, typically the individual will make the decision. And if the patient says, I want thyrogen, and they usually have a reason for that,
Right.
then we'll do that. So I don't have a problem with Thyrogen in this patient, but I want the patient to understand the options so that they don't come back and say, nobody ever told me that.
But the higher they get up on the risk category, the more you feel like treatment, are you leaning more toward hypothyroidism as I raise the risk here, or are you still in the middle there?
No, I'm not personally. So we just published an article of several patients with I-124 PET in Journal of Nuclear Medicine. This just came out last month. And we looked at, and I'm getting to your question with an undefinitive answer. And we looked at I-124 PETs with thyroid hormone withdrawal and with Thyrogen, recombinant human TSH, in the same patient with full dosimetry for 5 days. So we have full dosimetry for 5 days in the same patient as their own control. In distant Mets, which is not an approved indication for recombinant human TSH. And this process is much more complicated than we thought. We thought it'd come out and it'd be one or the other. It's very complicated, and each patient's different. But the short message is that it's different in each individual, and there is this balance so that perhaps you get a little more uptake with thyroid hormone withdrawal in the lesion, ergo you're going to deliver more rads per millicurie because you got more up. But you're also now exposing the normal tissues more because you're hypothyroid and you've got delayed clearance, and your dose to the bone marrow and other organs goes up. So we have to move from a different perspective of uptake, because I might get more uptake with thyroid hormone withdrawal than Thyrogen, but I'm going to clear a lot faster with recombinant human TSH so that I reduce my whole body dose. So maybe I just give a little more I-131 with a recombinant human TSH. So if I articulated that well enough, where we're headed is we need to look at millicurie to the tumor versus millicurie to the normal organs. And it starts to even out. You might give a little more I-131 with a recombinant human TSH because you're delivering less to the bone marrow. Salivary is a whole different story. So it's very, very complicated. So my undefinitive answer to you is as the risk goes up, and let's say they have metastatic disease, I come at it from the standpoint, my approach is, can the patient tolerate thyroid hormone withdrawal? And if they have comorbidities, lung, heart, et cetera, and the answer is no, it's a no-brainer, it's recombinant human TSH. If they can, then I sit down and I say, here's the pros, here's the cons, which would you like to go with? I'll do either or. And so that's how I approach it.
Megan, what about University of Michigan?
So we still do a lot of hypothyroid protocol, and definitely for the high risk, but even for some of the low risk, I'd probably prefer a little more Thyrogen use, to be honest, but that's just sort of how it's done at the U of M.
Kate, the traditional thing is after we've done, whether or not you do a diagnostic scan, you give your adjuvant therapy dose radioactive iodine, and then patients come back a few days later for a post-therapy scan. Is that necessary? Is it useful? Is it helpful? Do you guys do that in the UK?
Well, we don't do diagnostic scans, so this is our only opportunity to see where the uptake is. So yes, we do it in all. We find it very helpful in identifying what residual disease or remnant there is. We do a SPECT CT, so we do get the anatomical information as well. And it just, it's another bit of information into your ongoing risk stratification.
Yeah. So Doug, we gave him 150 millicuries, and the post-therapy scan lit up half a dozen small lymph nodes in the neck on the SPECT CT. The lung showed a fairly diffuse uptake, not the pediatric thyroid cancer, but definite uptake through the lungs. What's his follow-up going to look like? When are you thinking he may need to come back for another diagnostic scan, another dose radioactive iodine? Megan's going to do all the cross-sectional CTs for us, but when you see that positive post-therapy scan in a relatively high-risk patient like this, when are you anticipating needing more from your side of the fence?
And we did an empiric 150, or was this
we did an empiric 150.
dosimetry 150?
It was empiric 150.
Yeah. Well, there's no good answer to that. And so it's a practice. Now, early, and again, as I mentioned, Mike, you've published on this. He's, what was he, 35, so he's not in the 60, 70-year category. The Benoit and Leeper, when they were with us and speaking on it, they usually argued you needed to wait a year. But it was a very arbitrary decision with no data. Thanos Bikos from our institution went back and has looked at the CBCs over 2 years. And there's no question that with dosimetry doses, but you don't know if this 150 is the max or not, you will drop your blood counts, or you may drop your blood counts, and you may drop them significantly, not requiring transfusions or granulite stimulating factors, et cetera. But the data shows that you start coming back fairly well by 1 year. Actually, it continues out to about 2 years that it will come back. So with very weak data, although, there's concern about this patient, I would be looking to go at 1 year for an I-131 dosimetry. Now, I like a lot of TGs, so I'd like TGs at 3 months, 6 months,
Right.
and 9 months and 12 months on suppression, and I want to see that trend. And doubling time, Mayachi's data, Mona Sabra's data from your institution, et cetera. I want to see that data. I want a contrast CT. I probably can't get him every 3 months. I'm not worried about radiation. I'm worried about him not dying from this disease now. So I'd like contrast CTs fairly frequently to try to now see what was the response to the 150. Did the lesion, the structural lesion, decrease in size, stay the same, doubled? All of that's going to affect me. Now, if the pattern comes back, let's say we're at 6 months and the TG looks like a doubling time is 6 months and the CT is already going, I will consider another dose. But it's harder for me because I don't know whether that 150, he could have gotten 300, so he only got 100 rads to the bone marrow. But that's how I would approach it.
So in large parts, the early scans are looking for early failure, trying to get assessment of efficacy, but largely
Efficacy and
an early failure.
Right.
Megan, what would the follow-up in your hands look like in a patient like this?
So it would be very similar. A patient like this we would probably follow with nuclear medicine, and so at 6 months they'd sort of reassess, but ideally if they were going to give a second treatment it'd be closer to a year, but the minimum would probably be within 6 months after. We'd follow the thyroglobulin similarly and use that to help decide, when there would be consideration for whether or not a second treatment's needed.
Kate, are we just worrying ourselves too much? I mean, you're an oncologist. You treat real cancers and bad cancers. And I mean, they scan melanoma patients every 2 months, pancreatic patients every 2 months. Do I really need to be scanning this person with small volume disease at 2 months, or is this reasonable?
Well, we wouldn't scan that
So
frequently.
tell me what would you do to
So-
follow up this one?
So we would follow this, we would do 3 monthly clinical review and thyroglobulin. We would probably treat sooner than a year. We would, if there was residual thyroglobulin and knew that we had distant disease, we'd probably aim to retreat in 6 months, but we will have given an empirical dose which is likely to have had a lower overall whole body absorbed dose. But we might get a baseline anatomical imaging to assess the chest disease, particularly so that we can try and assess whether there's been a response. But we wouldn't be scanning every 3 months for that. We'd go straight to another therapy.
So Megan, I haven't heard much about ultrasound. I mean, traditionally, somebody gets their thyroid cancer, they come back in 6 months with the TG and an ultrasound. I'm hearing a lot more pictures and scanning than ultrasounds. Why in this case are we doing more than just our standard ultrasound follow-up?
Well, so we went down the path that maybe this patient had lung disease.
Yes.
If the patient just had regional disease, we'd rely, purely, or for the most part, on ultrasound, unless that thyroglobulin was higher. We thought that later there was some disease elsewhere. We would still do neck ultrasound in this patient, but I think it was just the fact that it was introduced the idea that this person had lung disease as well that we considered more systemic imaging.
Keeping an eye on that. Let's do one more and then we'll stop and move on to the next lecture. Let's take it sort of the ultimate high-risk patient. This person has 100% risk of distant metastasis because she presented with distant metastasis. 56-year-old female mathematics professor. I made it easy because it was the last course. That way you can tell percentages and you don't have to explain them. She understands percentages. Several-month history of persistent hip pain. X-ray shows a lytic lesion in the pelvis in a non-weight-bearing location. They biopsied the pelvis and surprisingly find follicular thyroid cancer. As usually happens, only after you have a diagnosis of distant metastasis are you desperate enough to do a physical exam and find a 6-centimeter mass in the thyroid. FNA was follicular neoplasm. Yeah, we sent it for molecular testing. That's good. RAS. She's probably going to surgery. Chest X-ray shows multiple pulmonary nodules. It's suspicious for metastasis. Pre-op TG is nearly 10,000. TSH is 1.2. Kate, before we talk about radioactive iodine, think about these patients that present with distant metastasis. You know, they always get the phone call, rush and do their total thyroidectomy so we can get to radioactive iodine. What kind of sequence of events do you sort of think through? Who goes first? How do you think about this sort of as an oncologist?
So it's reviewing the patient. What are their symptoms here? So we've got a diagnosis of cancer. If she's getting a lot of pain from her pelvic metastasis, then we would give it external beam radiotherapy.
And she did. So she was. That was what was the
first.
main thing that was driving her. We had her see orthopedic surgeon. It was structurally stable, way out in the wing. So we just did a single treatment shot of external beam radiation, and the pain got much better in 2 or 3 days.
Yeah.
Now she's back to see you.
Yeah, and then we would move towards working her up for her total thyroidectomy so that we could then be giving her systemic iodine.
In patients that present that way, do you do other chest CTs or other spine or brain MRIs? I mean, she's walking in the door as sort of a high-risk follicular thyroid cancer patient,
Yeah.
either now or at some point?
Yeah, no, we would, and I tend to favour doing an MRI spine when we've got bone metastases, just to predict before we have a neurological a problem. And from a radiotherapy point of view, I like to see the whole spine, and just to ensure that we can tackle something before it becomes a problem. So yes, we would fully stage her, and then if we're looking at then asymptomatic disease, we would ask our surgeons to consider total thyroidectomy so that we could then continue treatment.
So Doug, we staged her. She didn't have any brain metastasis, but she had several small metastases up and down the spine posteriorly, not near the cord, a centimeter-ish or so that you could see on the MRI. Asymptomatic, not hurting her. As we begin to think about preparing her for radioactive iodine and raising her TSH, do you worry about those spine mets? Do we use steroids? How do you think about that?
With great trepidation. The first thing that I would want to know is from the diagnostic scan, is there one, and this is a little heretical, so this I may get tomatoes from the nukes here. I want to know if any of those had if one of those had a lot of radioiodine uptake. So if someone came back and there was one particular area, a lot of little small ones, but one that was really, really intense with uptake, then and one would say, well, I can give the iodine and get a good rad dose to it. I would consider XRT, radiofrequency ablation, cryotherapy, embolization, whatever, because I'm trying to reduce that uptake in that lesion, which yes, I could probably treat, but will reduce my effectiveness to the potential other lesions in the spine. So I would go after that one, or consider going after that one, and then I would come back and do full dosimetry. And let me digress for a minute. So it's easy for me to say full dosimetry because I have full-time physicists, but there are, and then others will say, well, I don't have that, I can't do that. There are simplified dosimetry protocols out there. So there's by Hanscheid in Würzburg, Germany, Walter Jensen from Essen, Germany, for those who are here from Germany. Dr. Luster's in the audience, he's very active in that. And my physicist, Frank Atkins, has done simplified dosimetry, published that, and it's also been validated in a separate patient group, and it can be done in any nuclear medicine clinic. And that has compromises, but that can help determine a dose for that patient. So I do full dosimetry or simplified dosimetry, and then I would work with the endo, the usually it's the neurosurgeon on a decision on whether we're going to give steroids or not. And then there's the issue of thyroid hormone withdrawal and thyrogen. So everything becomes, the more you know, the less you know. So it's a real individual decision, and then ultimately we would administer that I-131.
So let's talk about thyroid hormone withdrawal versus thyrogen. Obviously, we're off-label at this point. Thyrogen's approved for ablation and adjuvant therapy. So any use we use of thyrogen in the setting of distant metastasis is off-label. Doesn't make it right, doesn't make it wrong, but we recognize that's not in the approval anywhere in the world that I'm aware of. Kate, where are you on these distant metastasis folks? Thyrogen, do you make them all hypothyroid? Are you somewhere in the middle? Where are we on this?
I've changed my practice slightly over the last few years, based a lot on patient requests and discussions. But I mean, I had started off with thyroid hormone withdrawal for all my metastatic patients. And the trouble is once a patient's done that once and they're coming back for the next one, they don't want to do it again. And so the indications or the sort of excuses that you can find to give recombinant sort of perhaps are a little, the threshold is lower. But generally, I would try to aim to withdraw still in this situation, and I would cover my treatment with some steroids in case you got bone flare, bone pain.
Megan, we mentioned this one was a RAS tumor, and probably no surprise, it's a follicular thyroid cancer. The bone mets were all very RAI avid. It lit up like a Christmas tree in multiple places in the spine and ribs. So we think radioactive iodine is likely to be helpful. In these patients that present with distant metastasis, your institution has the capability of doing huge genomic testing and analysis. Talk a little bit about how, are you guys using that now routinely, RAI refractory, RAI avid? How are you doing it in the distant met setting?
So first with the RAS mutation, I think a lot of us were really excited when the New England Journal of Medicine paper came out in 2013, where it showed that selumetinib could be used and it could enhance iodine avidity. And, you know, it was 12 out of 20 patients that were responsive, but it was like 5 out of 5 with the NRAS mutation. And so I think for those of us that treat thyroid cancer patients, that was especially exciting, because for so many of these patients with advanced disease, you know, we're putting them on medications that can, if it's advanced progressive disease, that can be quite toxic. So the idea of something enhancing iodine avidity was encouraging. We do not routinely, you know, send everything right now. We have been debating it. We still do occasionally Foundation 1 as like a send-out test where we can get sort of the extended panel and, you know, help see if it would help change management, especially like would you use selumetinib down the road. We've talked about in patients like this, you know, so the 5% with, you know, really aggressive disease, we have the capability to do it at our institution. The problem is it's just so costly. And so we talked with Tom Giordano, our pathologist, about it, and he sort of like wants one of the guidelines to okay it, and then that might enable us to get some more coverage from the patients for this testing. Right now, the only one that seems particularly helpful is if they're NRAS positive because of the selumetinib. You know, for the BRAF and the BRAF inhibitors, we're not as excited about it, but that would be sort of the mutation that may be beneficial.
Doug, we've talked for the last sort of few minutes here about sort of the importance of lesional dosimetry. Can you, for the group that sort of doesn't understand I-124 PET, what that is and where you see that going in the future and how it might help us actually pick administered activities when coupled with clearance in a patient like this?
So to back up, I-124 is just another isotope of iodine. The only difference is it's got an extra neutron in it. But boy, that changes everything. So I-124, I-131, and I-123 put out gamma rays, and that's what you're imaging, and I-131 puts out a beta, which is a negative electron, and that's what you're using for therapy. The I-124 puts out a positive electron called a positron. And that makes all the difference in the world, because now you have a PET agent and you can do your imaging of iodine on a PET scanner, and the images really are impressive. They're not quite as good as FDG, but that's a whole nother physics discussion, but they're still impressive. Initial data from Memorial, Walter Jensen, Freudenberg, multiple in our institution clearly shows that I-124 has better lesion detection, significantly better lesion detection. So it has great strength in helping to identify lesions that otherwise would not have been seen and therefore change early risk stratification. The other advantage of I-124 PET is that it allows great quantitation and therefore dosimetry, both whole body and lesional dosimetry. And so where one wants to get is to look at these lesions and say, you know, I cannot give enough I-131 to kill that tumor without delivering too many rads to the normal tissue, ergo I'll give none. Or that I can, or that perhaps I can treat some of them and not other ones. And it holds a lot of promise on that. And there's work with George Scores from Hopkins, from our institute, Memorial, and other institutions, Walter Jensen from Essen, Germany, looking at that. Now, the problem with I-124 is it's not approved by the FDA, and it's generic. So humbly, I've submitted the letter to FDA literally 1 month ago to try to request permission to pursue a new drug application based upon present literature. We have our fingers crossed. We do have a meeting in September. I think that will move forward. If the FDA agrees that we can pursue an NDA with the present literature, we'll probably have I-124 approved within the next 12 months after that September. If not, I'll probably be long gone before they get around.
Don't say that.
The bottom problem with the FDA approval is if we can't get it with the present literature, it's a generic iodine. So there's no patent for any commercial company. There are some other things that I'm not going into. They could get a small period of time, but there's no long patent for a commercial company to make the money back in order to get the FDA approved. It would be very, very valuable. It clearly is better for imaging, and it's really, really good for dosimetry.
So I think we've had a good discussion this morning. I think we've found that we probably have more common ground than areas that we disagree. And even the areas that we disagree, we've agreed to disagree and take a look at it. You've now learned that you can join this panel anytime because you don't have to be definitive, and you can just say, yeah, I might or might not do that. Please join me in thanking my panelists for a wonderful discussion.